Session 2, Emerging Concepts. We're going to hear from Drs. Peter Jessel, Dr. Federico Migliori, and Dr. Ryan Cunane, and we will have a panel discussion with question and answer on the other side.
Hi, I'm Pete Jessel from the Portland VA and Oregon Health and Sciences University, and it's my pleasure to review an update on shockwave therapy and other complementary tools. I have no related manufacturer disclosures. Lithotripsy for lead extraction is off-label, and these views do not represent an endorsement by the United States Department of Veterans Affairs. So I'd like to introduce our lithotripsy experience thus far by sharing our first case where we aim to demonstrate efficacy by imaging pre and post shockwave. I'll discuss the current evidence for lithotripsy for lead extraction. That'll be a shorter discussion given few new publications. I will review complementary imaging tools that help with patient selection for lithotripsy. So this is a 69-year-old with normal renal function, insulin-dependent diabetes, non-ischemic cardiomyopathy with a prior VF arrest 30 years ago, and an abdominal ICD that was with a lead tunneled to the subclavian vein. He had an abdominal pocket infection after the 5th generator change, which grew out Enterococcus faecalis. This was despite an antibiotic pouch being used. The referring electrophysiologist debulked the pocket, cutting the lead pin and removing the generator as a temporizing measure. There was no expectation that this would clear the infection, and the patient was transferred to our VA center. The patient had a dual coil endotac lead, model number 0064, which is quite an old model, 30 years, and very large, 11.9 French. We noted significant calcification in the proximal subclavian and innominate into the SVC. So here you can get a better look at the dense calcification along the proximal subclavian and into the SVC, whereas the distal lead into the heart is relatively free of calcium or contact with the heart. So based on the significant burden of calcium seen here, we thought this would be a good candidate for lithotripsy therapy. The first report of shockwave lithotripsy by Dr. Latanich and Anderson was published in 2023, and Dr. Latanich gave an excellent presentation last year at this conference, so I'll be very brief in my comments here. This was a retrospective analysis of 14 patients receiving lithotripsy. Patient selection was not guided by specific imaging, and the main finding was a reduction in active extraction time using powered tools, 15 minutes in the lithotripsy group compared to 28 minutes in 51 controls. And there was less variability in the extraction time in the lithotripsy group. There was one innominate tear in each group near stenotic sites. Both were able to be managed conservatively. Since this publication, there have only been 2 additional case reports, one from our group and another describing successful antegrade use of lithotripsy from the pocket axis after an initial failed attempt, whereas after lithotripsy, that was a successful procedure. So how does lithotripsy work? It's an electrical discharge that vaporizes fluid in the balloon, creating bubbles, which then generate an acoustic shock wave of up to 50 atmospheres, but with a very narrow radius, up to 5 millimeters or so. A total of 300 pulses are available. So what Dr. Latanich described and what we've been doing is delivering to approximately 3 segments, 90 pulses, using up most of those 300 that are available. The M5 Plus balloon is 60 millimeters in length and 7 to 8 millimeters in diameter, and that's what's been described being used in the literature. Importantly, it has a 2 to 1 to 2 emitter layout. And that's important because the pulses are split between those emitters. Thus, the middle electrode has the highest amount of energy, and it goes over an 014 guide wire. There is another balloon, the IVL-6, but that's relatively short, which makes it perhaps less suitable for lead extraction use, but does have high energy in all the emitters and can go over an 018 guide wire. For peripheral arterial disease, balloons may be sized by imaging, but for lead extraction with sheaths, especially those that are deflectable, sizing to the vessel is probably not necessary. So back to our case, we placed a number 2 lead locking stylet and dissected out the high voltage cables separately and tied those off. We performed lithotripsy from near the clavicle down towards that high burden of calcium area here, which you can see on fluoroscopy, and lining up the center of the balloon where that highest emitter is located. Due to the size of this lead, we did not perform prophylactic inferior snaring, which is our general practice for leads over 10 years. We decided to see how the case progressed before considering snaring. And as a first shockwave case, we elected to place the bridge balloon, so you can see the wire here. But that's not necessary. Moving forward, we haven't felt the need to do that. This patient did not require a long sheath to place the balloon for shockwave, but for many cases, we will use a deflectable sheath that's later used for prophylactic snaring purposes. So we used a sub-C 13 French to get started, which progressed relatively quickly, then moved to a tight rail, which you see here. And we had some challenges getting through that last highly calcified area near the proximal SVC, and used an outer sheath to attempt to get over that. Given that there was only one French size difference between the largest equipment we had and the lead. So here, the lead tip has already been freed, but we're still binding at the SVC, and finally it gives way and we're able to free the lead. The patient did well with no significant hypotension. The active extraction time was about 20 minutes. Both the lead tip and the proximal portion that was in the access pocket grew out enterococcus, so simply debulking the abdominal pocket would not have cleared the infection. We did something unique here for this case as a first lithotripsy case, which was to perform intravascular ultrasound pre and post shockwave. So on the left, we have a pullback from the subclavian back into the proximal SVC. Identifying the lead here is difficult because of how little vascular space is left. But as you pull back, you start to be able to identify the lead. And I'll just pause it here as we get into the SVC proper. And you can see this large shelf of calcium that makes it difficult to see the lead. On the right, this is post lithotripsy, where we see breakup of the calcium fairly well here, but again becomes more difficult as you get to the proximal subclavian. So pulling back, I think you can appreciate some of the calcium around the ICD lead has been broken up, and you're able to visualize that a little bit easier. So IVUS has been evaluated for lead extraction. This prospective study from the University of Chicago group evaluated IVUS use in 60 patients, dividing the lead course into 3 vascular segments. They graded lead adherence based on 3 factors: lead mobility, lead proximity to vessel wall, and lead-on-lead binding. They then graded lead adherence using IVUS pre-extraction. Variables related to extraction difficulty were collected, and the figure shows the median laser pulses here with 0 for grade 1, and then up to 3 for more difficult cases where essentially the lead was immobile and fixed to the wall, needing up to 6,000 pulses. They looked at the predicted difficulty with IVUS compared to a known risk scoring system, the lead extraction difficulty score, which is based on the number of leads to extract, the years from implant, also if the lead had a dual coil component or a vegetation. Most low-risk LED predictions were concordant here with IVUS. However, there was significant discordance, with 86% of those predicted to be high risk by LED were actually low risk by IVUS, and 9% who were low risk by the LED score were actually high risk by IVUS. CT has also been looked at to predict extraction difficulty. The MILES study was a prospective blinded multicenter study with a hypothesis that CT would demonstrate fibrosis severity and predict extraction difficulty. The inclusion criteria was lead dwell time over 1 year, and they excluded patients with atrial fibrillation with rapid ventricular rate and those not able to receive contrast. So the grading was, again, based on lead characteristics, with grade 1, the lead being within the contrast-filled lumen, then grade 2 and 3, how much of the lead was abutting the vessel, up to grade 4, where the lead was actually outside the contrast-enhanced lumen. So did CT change the approach to extraction? I believe the authors would say it did. They abandoned 4 leads and surgically removed 3 leads. They had complete success in 95% of leads. They did have 5 major complications, 3 of which were vascular lacerations in the proximal vessel. Powered sheath use was significantly higher in patients who had a higher fibrosis score of 3 to 4. And here you can see in this violin plot that the duration of extraction and the duration of fluoroscopy was significantly longer. So can CT predict difficulty? I think it can, which can aid pre-procedure planning. A dedicated CT protocol can systematically identify fibrosis and calcification. IVUS also can be helpful, giving real-time guidance and does not use contrast. But the imaging may be limited by excessive calcium or venous occlusion. Although IVUS is promising, we haven't continued to use it due to the modest additional time and the cost of the extraction. Our VA center has begun a pre-extraction CT protocol with our cardiac radiologist, and that may help in deciding which patients who benefit from intravascular lithotripsy. So questions do remain. What is the risk at stenotic sites? Venoplasty is very safe, but is shockwave in some way different? Any kind of safety signal could be masked by the overall low vascular risks in lead extraction. So far, we haven't seen any issues in our cohort. We've done over 30 cases with lithotripsy now in leads over 10 years old, and we'll be presenting our work as an abstract at the Heart Rhythm meeting this year. Is there any risk to retain functional leads? I think one thing to keep in mind is that lithotripsy has no transfer of thermal energy. In my mind, mechanical and thermal energy seem to be more likely to cause problems during pocket manipulation, but time will tell. And how effective is lithotripsy for lead extraction? More work definitely needs to be done here about which patients are going to be the ones to benefit. Prospective studies are needed, and I think imaging would be an important part of any sort of study to look at that. So in conclusion, lithotripsy is a promising new tool to assist the most difficult extraction cases, but questions remain. Patient selection needs to be improved. Does all dense fibrosis benefit, or only those with true calcium formation? Prospective studies would help evaluate this. And imaging can assist in challenging extractions, potentially identifying those patients who would benefit from this exciting new therapy. I appreciate your time. Thank you.
Good morning, everyone. I'm Professor Migliore from Italy, and it's a pleasure for me to be here with you and to discuss about the damage of the tricuspid valve during transvenous lead extraction and how to identify and prevent. These are my disclosures. We'll address these issues. First of all, the anatomy of the so-called forgotten valve, the tricuspid valve. And then we'll try to answer to these questions. Did we forget about the tricuspid valve in lead extraction procedure? What to do now and how to avoid the tricuspid valve damage during lead extraction? To understand the potential damage of the tricuspid valve during or following transvenous lead extraction, is essential to know the anatomy of the tricuspid valve. The tricuspid apparatus comprises the leaflets, the papillary muscle, the chordal attachments, and the annulus that forms the tensor apparatus. So, what about the prevalence or incidence of the tricuspid valve damage following lead extraction procedure? Because safety is an essential clinical endpoint of transvenous lead extraction, and the most dangerous and feared complications of the transvenous lead extraction is the SVC laceration. However, also tricuspid regurgitation from valvular damage can also occur following transvenous lead extraction. And this issue is an underdiagnosed issue. However, if we perform transvenous lead extraction under TE guidance, the prevalence or incidence of tricuspid regurgitation and damage of the tricuspid valve rises up to about 12%, as you can see here in this study. And interesting, the only independent predictor of tricuspid regurgitation and damage is lead implantation duration, as you can see here. And why? Because the fibrotic process in chronically implanted lead can entrap the lead into the tricuspid valve apparatus, as you can see here in these figures. This is a recent paper from our group, and we demonstrated that if we use an echocardiographic evaluation pre, during, and after transvenous lead extraction, in the majority of patients following lead extraction procedure, we didn't observe a significant tricuspid regurgitation increase. However, in about 6% of patients, we observe a significant tricuspid regurgitation increase. And we confirm that duration of lead implantation is an independent predictor of significant tricuspid regurgitation increase. And it's interesting, severe increase of tricuspid regurgitation was an independent predictor of mortality in our patients. And this is why we are here to talking about to these potential serious complications of the tricuspid of the transvenous lead extraction. That means tricuspid regurgitation. Currently in vivo, using both two-dimensional or more recently 3D echocardiography, all the three leaflets of the tricuspid valve can well visualized, and also using the echocardiography evaluation, we can observe that the leads can be adherent, stuck, impinging, or integral to the tricuspid valve leaflets. And so why is so important to observe or to identify the presence of significant adhesion to the leaflets of the tricuspid valve? Because strong adhesion can predict the significant tricuspid regurgitation or damage following transvenous lead extraction, as you can see here in this very important study. This is a case of systemic infection, as you can see here, the vegetation. So we extracted all the leads, also using the AngioVac, as you can see here from the right side, the dwell time was more than 10 years. However, immediately after the transvenous lead extraction, I noted a damage of the tricuspid valve, leading to a severe tricuspid regurgitation, as you can see here. So unfortunately, the patients underwent a few days after the procedure successful cardiac surgery, as you can see here. This is another case. Again, systemic infection. We perform the TTE evaluation before lead extraction. As you can see here in the middle, there is vegetation. On the right side, there is no significant tricuspid regurgitation before lead extraction. I perform lead extraction procedure. As you can see here in the left side, I started with manual traction. However, immediately under the guidance, I noted a damage of the leaflets of the tricuspid valve, as you can see here, leading to a significant tricuspid regurgitation, confirmed by the TTE echo after transvenous lead extraction procedure. As you can see here, significant tricuspid regurgitation. So what to do now and how to avoid tricuspid valve damage following lead extraction? So I think that, in my opinion, is very important a multimodality imaging evaluation before lead extraction and, of course, during and after lead extraction. Because I think that in case of important fibrosis, physician tends to pulling excessively to facilitate the advancement of the sheets over the leads, increasing the rail effect. Usually, I prefer to use before lead extraction CT scan to detect the fibrosis. As you can see here in this case, important fibrosis surrounding the lead at the level of the superior vena cava. And unfortunately, fibrosis is impossible to detect under fluoroscopy during lead extraction. And on the right side, this is the TE examination before and during lead extraction. As you can see here, important fibrosis surrounding the lead. So please pay attention to this very important imaging, because the lead, this is a transgastric view using the TE evaluation. The leads, as you can see here, is stuck to the posterior leaflet, and this imaging is very important to see because this imaging is leading to an increased risk of tricuspid valve regurgitation following lead extraction procedure. On the right side, this is the color view before lead extraction. As you can see here, there is only mild tricuspid regurgitation. And so pay attention, please, what happened during excessive traction, during lead extraction procedure. The lead can entrap and wrapping the lead, leading to important and significant potential risk of the tricuspid regurgitation and damage following tricuspid regurgitation. So in this case, I avoided excessive traction. I advanced the sheet, in this case mechanical sheet, using the oversheet for me is very important. So slowly, step by step. And so in this case, I avoided complications, including tricuspid regurgitation, as you can see here. This is another case. The lead extraction procedure was unsuccessful from above. So I tried to, I extracted the right ventricular lead from below using a snare, as you can see here. I crossed the tricuspid valve using snare. I extracted the lead. However, as you can see here, there is very important fibrosis and unfortunately significant tricuspid regurgitation following lead extraction procedure. So I think that the extraction from below uses snare is potential dangerous, and so please, I think that it should be avoid this procedure. And the patient underwent successful cardiac surgery using a mini thoracotomy and epicardial pacemaker leads implantation. So I think that the first take-home message is that transvenous lead extraction is not a sex extraction to avoid complication, especially tricuspid regurgitation and damage following lead extraction procedure. This is another case, non-infected lead. As you can see here, this is the 3D TTE evaluation before lead extraction, and the lead is stuck to the posterior leaflet. So again, this is a very important imaging before lead extraction procedure, because this imaging can predict tricuspid valve damage following lead extraction procedure. So again, I perform the procedure under the guidance, as you can see here, and please see a lot of fibrosis surrounding the lead here. And so please know what happened during lead extraction procedure. Again, I avoided excessive lead traction during procedure. I advanced the sheet and the oversheet slowly, step by step, in the absence, and extracted the lead in the absence of any complications, including tricuspid valve damage. Another case, 4 leads to extract for infection. This is the evaluation before lead extraction. There is no tricuspid regurgitation before extracted all the leads. The dwell time was more than 10 years. Immediately after the procedure, I noted this imaging, and the question is, what's that? I noted a significant tricuspid regurgitation. However, I noted also that after lead extraction, there is an important dilatation of the annulus. So this is no tricuspid valve damage after the lead extraction procedure, but this imaging is very important fibrosis, as you can see here in the extracted leads. So after the after the lead extraction procedure, if we note the significant tricuspid regurgitation, is very important to understand also the mechanism, because not all the significant tricuspid regurgitation are due to a damage following transvenous lead extraction procedure. So in conclusion, I think that the preoperative multimodality imaging evaluation before lead extraction is essential, using CT scan, 2D echo, and 3D echo. The importance and utility of the lead extraction so-called toolbox, implying the having a variety of tools available, increases the success and safety of the procedure of transvenous lead extraction. An excessive pulling of the extracted lead during transvenous lead extraction to ensure a real effect for advancing the sheets along the target lead could increase tricuspid valve damage. It is my feeling and impression that excessive and uncontrolled pulling can cause the extraflation and wrapping of the leaflet, leading to an increased risk of tricuspid valve damage. This dangerous phenomenon, however, cannot be seen during fluoroscopy, but is well visible by means of TE monitoring. Control and non-excessive traction and gentle advancement of the sheet during using the outer sheet over the target lead can reduce the risk of damage of the tricuspid valve during the procedure. And finally, cooperation with TE monitoring may help warn the operator about potentially harmful situations leading to tricuspid valve damage. Thank you for your attention.
Hello, my name is Ryan Kinane from the University of Michigan, and I'll be talking about extraction of leadless devices today. Here are my disclosures. And for an outline perspective here, so we're going to be doing a quick case presentation, a brief review of why do we extract or retrieve these devices, review of the published data, how to approach a case, and if we have time, a couple of other cases. Here is the initial case presentation. This is an inpatient consult for a 73-year-old man who had PEA arrest and subsequent complete heart block after resuscitation, and now is having issues with an unstable temporary pacemaker. He originally presented about 2 months prior to this after suffering large total body area skin burns, including much of his chest, due to an accident with some accelerant in his garage. Since then, he's had numerous burn debridements and skin grafting in the chest, arms, and all over his body, with more planned. He has a left ventricular ejection fraction of 65%, and it's December 2016. The Medtronic Micra transcatheter pacing system was approved by the FDA just a few months prior. So in light of this, and given the availability of this new technology, we were concerned about wound healing with an anterior approach to transvenous device implantation with him. So we decided to move forward with a Medtronic Micra implant. Here is the initial deployment of the device. This is maybe somewhat more apical position than I would choose now, but again, this was early days of implantation for these, and we had a good result. Here's a subsequent EKG showing complete heart block and good capture of the device. He did well for many years without issues. We were keeping a close eye on his ejection fraction, kind of knowing that he was fully dependent. And in 2018, we saw a little bit of a drop to 58%, but he was clinically doing well. We decided to keep on monitoring that. About a year and a half later, stable, maybe a little less. In 2022, however, he started noting increasing fatigue, dyspnea on exertion, and echo at that time showed a new EF of 40%. So at that point, given his high pacing burden, 99+%, we decided he met block HF criteria for cardiac resynchronization. So we brought him back to the lab in May of 2023 after about a 6.5-year dwell time of his Micra device, and decided to do an attempt at retrieval and upgrade to a CRTP. Here are just some initial views of his device. You can see the RAO on the left, LAO on the right. His position. And here we've got a dedicated retrieval catheter in place. We'll go over this, the details of this a little bit more later. And on the left panel here, you can see we're kind of going after manipulating the device. It's a deflectable sheath in an attempt to snare it with that multi-loop snare. Unfortunately, I didn't get a shot to save the video of actually snaring the back end of the device, but here we have control of it. And we're advancing this protective sleeve over the device. You can see it kind of sliding over here. My pointer's at the tip. It's starting to bulge out as we're providing counter traction and pulling the device and pushing on the sheath, and eventually the tines release and we pull the device into the body, the protective sleeve, and out of the body. Here's the final view of his system. He's got CRTP with a quadrupolar CS lead, and again, he's dependent, so we had a temporary pacemaker in place, and we're just pulling it out at the end there. Overall good result. He's since seen an improvement in his ejection fraction and overall heart failure status. So why do we do this? There's been a number of published studies about kind of the experience of leadless device removal. None of them are huge, but we've got on the left here some of the early data from Dr. Reddy's lab on the nanostem experience. Nanostem kind of evolved into a VEER with some changes. The nanostem was never FDA approved, but a lot of these were clinical trial patients that had to be ultimately removed. And why do we do it? For them, this was a known issue with their battery having a precipitant in it and causing early battery depletion. So most of these were done for a battery failure, but a fair number of them required device upgrades or changes in the pacing threshold. Notably here, none of these got infected. These data here in the upper right are from an experience that I was participated in with some of the multi-center trial, main author being from Ohio State. We published the overall worldwide experience of micro retrievals to date. Again, this was early on. This was in 2018. But at that point, the bulk of the patients, again, were retrieved due to issues with pacing capture threshold. But some didn't require a CRT upgrade or ICD upgrade. There was one patient that was infected with sepsis, another that there was a possible vegetation on the device. And then a number of them were used as a bridge. So a patient that was pacemaker dependent, got their transvenous device taken out and micro put in to cover them while the infection cleared, and subsequently got a destination device later on. These are data that are yet to be published that was part of a multi-center study with some colleagues in Zurich. And we should publish, or we're submitting 85 patients that were all MICRA, but the bulk of whom were explanted due to the need for upgrade. So whether it be dual chamber system, about 9-10%, or upgrade to a biventricular system, roughly 22%. Also there was some pacing threshold issues, about 20% of patients. And then, but a good percentage of them, 23-24%, were implanted as a bridge option again, temporary. This is supposed to be due to CID infection. You can see the breakdown of other reasons here. There were a few infections in this group and a few dislodgements as well. Whenever we talk about micro retrieval, I like to include this study. I think it's impressive. This is the first in human experience of micro retrieval or removal. And in this example, this group from Yale got this device out, but did it in the hardest possible way. When they put their snare in, they actually got one of the tines first, and instead of letting that go, they kind of smartly put another snare in and went after the opposing tine so that they could straighten the device out and pull it into the introducer sheath backwards. But we were able to get it out, and we're successful at it. So kudos to them. More commonly used approach is to snare the back end of the device. In the MICRA, this is called the proximal retrieval feature. In the AVEIR, it's called the docking button. For a MICRA, you can basically grab it and pull, and the tines will, the nitinol tines will deflect back and kind of open up and release. If you can grab it. In the AVEIR system, you grab it and you have to counterclockwise torque it to release the active fixation helix. And that requires a specific catheter. Again, we'll go into that a little bit later. So these are data from the AVEIR/NanoStim experience. Again, this is newer data. This is actually going to be published in a week or two in JACC. It's this month's issue, March 25th, I think is when it's coming out. But this is 230 patients, and it just goes through kind of their experience worldwide with longer-term indwelling devices. And you can see the overall success rate was pretty high, 88%, and the range there, so the total of 234 attempts, there was 233 patients, but 234 attempts, and the range was from 6 weeks old to 9 years. If they break it down by dwell time, pretty consistently high success rate, surprisingly 100% success rate in the older devices, and actually better than some of the younger ones. If we look, and I'll go into a little detail later about why some of these can be unsuccessful. These are the available MICRA data. So on the left here, this is our 2018 publication, showed that overall success rate was high, so 100% success rate, none of them were abandoned. The times that the overall procedure time was about an hour, fluoroscopy time about 15-16 minutes. On the right here, again, this is that data from myself and the group in Zurich. Here we show, again, very high success rate, 95%, but for unsuccessful attempts. The devices were mostly on the septum, few at the apex, none in the RPOT, and we went through the reasons for expectation already. Most of these were done with an Agilis, that's a steerable sheath, but increasingly more and more with the AVEIR retrieval catheter. There were a few done with the delivery catheter as well, the micro delivery catheter. And then these are the snare breakdown of what was used to get them out. So how do we do this? So I kind of briefly mentioned a little bit about these different approaches. This is the most common approach. So it's using the micro introducer sheath in the right femoral vein. Through that, 14 French short sheath, something 14, 16, 18, whatever you have available, something that's a step down from the micro, 23 French inner diameter, and that'll allow for the Agilis to fit through, because if you just put the Agilis in the micro introducer sheath, you'll get feedback around the hemostatic valve. So this is just a step down, doesn't have to be anything specific, just has to fit the Agilis through it. And then through that, some snares. So here's the example of the Agilis catheter. You can use single loop snares. These are one snares. These are goosenecks. My preference is to use a multi-loop snare. It just increases the degrees of freedom, likelihood that you can catch something. In addition to that, I like that it's kind of coaxial once it grabs the device to pull it into the introducer sheath. And then the second approach would be using the micro delivery system itself. So if you have just implanted the device and pull the tether out, decide you want to get it out for whatever reason and don't want to use any more tools, you can use the microdelivery system. It's significantly more challenging because of the limitations of the system itself. You can fit a snare through the tether port in the device itself, but it has to be small in order to fit, and so that makes it a little more challenging. The best way to do this is to use the cup of the delivery system, try and get it over the back end of the micro itself, and then just try and snare that proximal retrieval feature with the tiny little snare while you have control of it with the cup. More recently, people have been using the dedicated Avir sheath. So we've kind of touched on this a couple of times already, but Dr. Wilkoff's lab proposed this in a publication in July of 23. And at that point was one of the oldest micros explanted at that point, about 5 years old. And they used this system. And so this was designed to remove the Avir. And what it has is a multi-loop snare through a deflectable sheath. The main advantage here is for a micra, you have this protective sleeve that you can then advance over the device and provide counter traction. I guess that's an advantage for the Avir as well, but it helps with the micra, and then it also protects the tines as you pull it back through the tricuspid valve from potentially catching on anything. You have to use this system to get the Avir device out, and that's because it allows for both grabbing onto the back end of the device and counterclock torquing it to release the helix from the endocardial surface. Here's just an example of this. You can see this is from Dr. Wilkoff's paper, or the Callahan-Wilkoff paper. You can see on the left here, the device, the snare interacting with the device. Eventually, it's snared, and then the sheath the sleeve starting to kind of come over the back end. In the upper left panel on the right, you can see that sheath kind of pushing in. You can see as we're kind of advancing the sheath and pulling on the device, you're kind of providing counter traction until eventually the tines release, pop into the sleeve itself, and then you can pull it out past the valve and into the introducer sheath. Here are just for our single center experience, what we've done. Total of 32 retrievals to date. All of them so far have been micros. We do implant Avirs, but we haven't had a lot of indications for retrieval yet. The main reason for our retrievals has been we're pretty aggressive with a bridging strategy. So we use these devices. Somebody comes in who's dependent and has an infection, we'll extract, implant a micra or whatever Avir, and then fully complete their course of antibiotics, bring them back, remove the device, and then reimplant the destination system. We tend to remove the temporary leadless device because I don't want anything potentially seeding the new implant. The bulk of our approaches have been using the deflectable Agilis catheter. However, we are increasingly using the retrieval catheter more and more. And our success rate has been high, roughly 95%, around 94%. So what makes these things unsuccessful? In the initial micro data that we published in 2018, we had 100% success rate, so that was great, but I think that's not realistic in the longer term as more and more of these are attempted. In the nanostem Avir experience, it's been about 12%. In our data with the Zurich group, roughly about 5%. And the most common reason for failed retrieval is inaccessibility of the proximal retrieval feature. That's what it's called on the micro, or the docking button on the Avir. So basically what you use to try and grab onto it to provide traction. I'm going to just go through a quick case here that illustrates this, I think, pretty well. This was a 72-year-old male, quadriplegic due to a spinal cord injury playing hockey in 2022 in his early 70s, impressively. And he had a micro implanted at that time in an outside hospital because of long pauses during trach suctioning. He's since had his trach removed. He's 100% V sense, 0% V pace at VVI 30, and he wants the device out because of possibly qualifying for a spinal cord stimulator trial that he wants to get involved in, and part of the protocol is you can't have the pacemaker. You can see here on the left panel, I've got the Avir sheath in. We do multiple passes with the snare trying to grab the back end. Similarly, we kind of weren't successful with the Avir, so I got an Agilis put in, have a multi-loop end snare in, and every time we're trying to get at this back end proximal retrieval feature, it's just deflecting around it, and can't figure out why I can't interact with the device at all. Eventually, we put ICE up to try and get a sense of what's going on, and you can see, just to orient everybody here, in the RA on the top, RV on the bottom, tricuspid valve in the middle, and then the micro device is sitting right here, just tucked in basal underneath the tricuspid valve. And I think what's happening is we're trying to get the snares in here, and the valve leaflet is just protecting the device and not allowing us to get to the back end of it. Here's just another view of that. A little zoomed in. You can see the device again tucked in right underneath and looking almost in some ways adherent to the tricuspid valve leaflet. So because we weren't successful from below, we did try and do it from above. And on the left panel here, I was able to get a wire underneath the device. So that's coming down from the right IJ with the introducer sheath, a wire, a woolly wire going underneath the device and up into the RBOT. Here I have an Agilis going in adjacent to that wire with a snare in it. You'll see the snare advance out. It's a multi-loop end snare, and we're basically trying to snare this wire. In this panel on the right, and if you keep watching this, eventually you'll see it, but eventually I got control of that wire with the snare. And now we have control of the main body of the device, and I can pull on it, pulling, and it's not releasing. I was hoping at this point to get the back end of the device free so I could then snare it, but it wasn't releasing. Here in this panel, we've still got control of it, but now I've got another snare in. These cases are good for the snare companies, but trying to get onto that back end. But again, everything is just deflecting around it. And ultimately, what we figured out was that the back end was in fact adherent to the tricuspid valve. Here in another pass, we actually got a hold of one of the tines, but we're pulling on that and couldn't get it out from that way either. So ultimately decided not to attempt to get this one out and just leave it be for fear of damaging the tricuspid valve. So just in summary, the available devices are designed to be able to be turned off. I think there are legitimate scenarios where removal, extraction, retrieval, whatever you want to call it, can be considered. The published data show that the procedure can be safe and oftentimes is successful, even in chronically implanted devices. Most common approach is to use a deflectable sheath with a snare in it, but the dedicated Vivere retrieval catheter is gaining popularity. And generally, if we can't get them out, usually it's due to some inability to access the proximal retrieval feature or docking button, depending on the system. And you can see that can be due to trabeculae, valve issues, or even encapsulation, as you can see on the photos on the right here. And that's it. Thank you very much.
What a great series of presentations. Thanks to all the presenters. And thanks to those of you who are advancing questions to us. I'll try to get to as many as I possibly can. So let's go in order, and let's start with Dr. Jessel. A lot of questions have come up about this really interesting addition to extraction, trying to disrupt calcified tissue. And a number of themes came across from the questions from the audience. The first has to do with an occluded vein scenario. The obvious question is, if you can't get the balloon past and parallel to the binding site, what do you do? Do you use a different technique to get through first? Are you able to abut the end, one or the other, or both ends of the occluded segment and apply energy there and gradually work your way into the occluded segment? How do you handle that?
Yeah, that's a great question. I think you could approach it a few different ways. As we saw in Dr. Love's earlier presentation, he actually went over a lead extracting first and then applying the balloon after creating that channel. So that's one approach you could use. A second is to address it from both sides. I haven't done that, but there is a single case report describing using the system, the shockwave system, from an integrated approach from the pocket. So it's certainly possible to do that. At that point, you know, when you're having that much of an occlusion, I think it becomes a real challenge in terms of the way you're able to get past that. So in summary, I think you know, shockwave will be a great addition to our tool bag that we have in extraction.
Addition question that comes up has to do with distinguishing proximity of a lead to tissue versus fibrosis and adherence. And you had talked about, you know, IVUS versus CT screening. How can you tell whether a lead is just lying up against something or truly embedded? And I'll add to that question about the calcification component, because a lot of your risk score really had to do with fibrosis, excuse me, and binding, and not maybe as much the calcium content of that binding tissue. So just a little more fleshing out of the imaging and figuring out how the leads are bound.
Right. I think there is still quite a bit of work to be done when it comes to shockwaves affect the tissue specificity. Is it really only helping us in calcified areas, or does it also assist in breaking up dense fibrosis? So I don't know how practical animal models would be in this scenario. You know, the fibrosis forms over years generally. So I think further study needs to be done on tissue specificity, getting that at that question of calcification versus fibrosis. We've applied a general approach, just using it in folks who have leads older than 10 years old, or those who we think are particularly high risk based on perhaps some of the other pre-procedure imaging features. So again, I think more work needs to be done. We're thinking about doing a prospective trial that would try and answer some of those questions. IVUS in particular has some advantages in that you can see in real time how you're affecting those fibrotic lesions. Certainly, there's some evidence showing that IVUS can show how much the lead is interacting with the vessel wall. In our case that we used IVUS, it was a challenge to see the lead when you had very little lumen body left. So in those areas where there's significant stenosis, it may still be a challenge to image properly. I think practically, CT has some advantages in that it doesn't add any additional time to the procedure. And when an expert uses some of these scoring systems for reading the CT, I think it could be a real advantage to targeting and identifying which patients may in fact benefit from this.
Yeah, along those same lines, and this ties into a previous presentation where Dr. Love talked about this new vibration tool. I wonder if hearing about this internal vibration modality of disrupting scar changes our thinking with this lithotripsy technique, and maybe indeed some of the effect isn't just on calcified tissue, but more the fibrosis itself, and maybe there is a vibratory or some other method of disruption of non-calcified fibrous tissue. So I wonder if that new technology, that presentation, affects your thinking and what the mechanism is pathophysiologically of lithotripsy.
Yeah, I mean, you could even wonder if just balloon dilation itself offers some sort of disruption to fibrosis between two leads sitting in close proximity or to the vessel wall. So the fact that you're inflating a balloon, we have not sized the lithotripsy balloon to the size of the vessel, but that's what is commonly done in other, peripheral scenarios. But you wonder if using a bigger balloon, causes more mechanical disruption. We've stuck with the M5 plus. There is, as I mentioned in my talk, a different balloon, the IVL6, that has higher intensity. So the downside for that balloon is it's only 30 millimeters long, so it'll be sort of a more focal approach. But if you're able to identify specific areas by imaging, I think you could potentially use that higher intensity balloon for more discrete, either dense fibrosis or calcified areas.
One of the imaging modalities that you showed, I think it was an IVUS before and after picture, seemed to show some calcified tissue that was disrupted but remaining in place. The question has come up about pulmonary emboli, and have you done post extraction imaging to see if in fact there are any particulates of any consequence that go into the pulmonary bed after doing lithotripsy?
Yeah, that's a great question. We have not systematically looked at post-procedure imaging. I think in lead extraction in general, there's probably a lot of debris that goes to the lungs that we're simply unaware of, and that fortunately patients tolerate quite well. When we're extracting infected leads that have small vegetations, we generally aren't too concerned until they are very large, much larger than the debris I would imagine we create when using shockwave lithotripsy, which would tend to be, I think, smaller pieces of debris that most patients would tolerate well.
Yeah. Thank you. I'm going to move on to Dr. Migliore's talk, which is one that gives me a lot of anxiety, the interaction between bound leads and the tricuspid valve. And a number of questions have come up looking at that from different angles. One question that came up repeatedly in different forms has to do with intraoperative imaging and how you use that information to change perhaps your decision making or to approach during the procedure? For example, are there findings that would convince you to use laser versus a rotational tool, or whether to use a superior or an inferior approach, or whether to simply stop and refer to CT surgery? What intraoperative things do you see that might change mid-course what you're doing?
This is a very challenging question. So, first of all, I think that before intraprocedural imaging, I think that it's very important a multimodality imaging before to assess the potential risk of tricuspid valve damage. I mean, CT scan and the TE, because as I tried to show you during my presentation, it's very important to see the presence and the localization of the lead between and across the free leaflets. And this is because, as you can see, if one lead is stuck to one leaflet, this is a very important sign to a potential increased risk of tricuspid valve damage. And this is very important to discuss also with our patients, because usually physicians and patients are afraid to about SVC. However, we will know that also the tricuspid valve can occur during or after lead extraction procedure. During the procedure, I think that TE evaluation is very, very important, because as you can see, we can obtain again, we can see the again the localization of the lead, but also we can see the movement and the relationship between the lead and the tricuspid valve apparatus during lead extraction, because lead extraction procedure, because I can as I showed you, during excessive traction, we can see a potential extraflexion of the leaflets, and this is a very important sign associated with a potential increase of tricuspid valve damage. I never I don't use the ice. Probably also the ice is potentially useful for the detection of tricuspid valve damage during lead extraction procedure. And what about the type of tools? I don't believe that there is an association between the type of tool, I mean laser or mechanical sheets, with the an increased risk of the tricuspid valve damage. Tricuspid valve damage can occur with all tools.
To push you one step further, is there anything that you would see where you would just simply stop the extraction and refer to a surgeon?
Yeah, if we see a very important fibrosis, I mean the lead is very stuck to the leaflets, and we have also a severe tricuspid regurgitation before lead extraction procedure, we can think about it. A multimodality approach, that I mean a hybrid approach, using the transvenous lead extraction and cardiac surgery.
Do you find that snaring the lead up front can reduce the risk of traction and the premature traction on the tricuspid valve?
Yes, probably also these tools is potentially useful to reduce the risk of tricuspid damage and regurgitation.
Do you think we like to pride ourselves as extractors on being good implanters because we see the consequences of other people's implants? Do you think there's any advice or techniques for implantation of a lead across the tricuspid valve that may reduce future risk of tricuspid valve binding and injury?
Yeah, this is a very challenging question. There are a lot of studies demonstrated that probably if we put the lead at the apex, we can have an increased risk of tricuspid regurgitation following lead implantation. Other physician colleagues tell us that probably using if we implant a lead in the septum, we can reduce the risk of tricuspid regurgitation. Now we have the conduction system pacing. Probably also with LBB pacing, that means left bundle pacing, we can have also tricuspid regurgitation. Probably the best way to avoid tricuspid regurgitation following implantation is to perform immediately after the implantation an echo view. Probably we can use also TE during the procedure, but I mean it's a problem because we have to use a general anesthesia. But I suggest to perform immediately or the day after implantation an echo to assess if we have a tricuspid regurgitation, because after one day we can remove immediately the lead and perform a new implantation.
I was taught to implant by creating a large soft loop of the lead in the right atrium and prolapsing into the right ventricle rather than trying to use a curved stylet and leading with the tip, hoping that you're not going to catch with the prolapse technique a cord or go through any fenestration in a valve leaflet. I believe that's helpful, but I don't have data to support that. And I wonder if, in fact, that approach is a good advice as we teach our fellows how to implant.
I'm completely agree with you. And this is very important because sometimes the damage of a tricuspid valve can occur immediately or during lead implantation. And this is very important because sometimes we see the tricuspid valve damage or regurgitation increase after lead extraction procedure, but probably the damage is before the after lead implantation. And so it's very important to avoid the damage also during implantation.
I'm going to move on to Dr. Cunane. There were questions that came up about preoperative imaging to anticipate full encapsulation or accessibility of the terminal docking button or the end component. Is there anything that you would do ahead of time in procedural planning that might convince you to not even attempt or use a different approach?
Unfortunately, I don't think that there is the fidelity of the available imaging modalities that we have right now is not good enough to identify whether or not the encapsulation is significant enough to prevent snaring of the proximal retrieval feature or the docking button of the device. I think that the imaging could potentially lead you to identify situations like the one that I presented, where the device is kind of blocked by the tricuspid valve, or potentially like kind of deep in some trabeculae or something. But outside of that, the encapsulation I don't think is readily identifiable on imaging. And to a certain extent, the degree of encapsulation, if you have complete encapsulation, it's not necessarily whether it's complete or not. It's more about the thickness, I would think, of the encapsulation itself. If you have a thin layer of encapsulation that includes the docking button or the retrieval feature, I still think you could probably capture it and just allow that to kind of break or tear and as you're pulling out the device.
Yeah. On the theme of implant technique impacting extraction, I wonder if your experience with removal of leadless pacemakers has in any way impacted how you implant. Is there a certain location or a certain technique to try to avoid the device end falling underneath a tricuspid leaflet, for example? Probably it's more driven by avoiding perforation and putting it on the septum, both for maybe some degree of synchrony and also reduced risk of perforation. But what about thinking about future extraction?
Yeah, it's hard to, to a certain extent with leads as well, transvenous leads. We when I was in my fellowship at the University of Chicago, one of our echo colleagues did a 3D echo study looking at leads and trying to place them in a specific spot within the commissures, and then going back months later and seeing if they are still there, and they move all over the place. So really, it's hard to really target a specific location on the proximal aspect of a transvenous lead. And I feel somewhat similar about the leadless device as well. We can target the distal tip, and we're replacing that on the septum ideally. And but how that kind of settles into its own position after we release or let go is we have a little less control over. That being said, with the shape of the devices, the micra being kind of squatter and shorter, and the Avere being skinnier and longer, you do have to target a little more of an apical position with the Avere to avoid interaction of the proximal aspect with the tricuspid valve.
a question came up about management of leadless devices that can't be removed, about turning them off or interaction with other leadless devices or transvenous devices. Any thoughts on how to manage these devices if they can't be removed, either from a physical location standpoint or a programming standpoint?
Sure. So both of the commercially available systems now can be turned completely off, which is different from a transvenous system. So that's certainly an option to just turn it off and add an additional device in place. There are some data from I think somewhere in Minnesota where in the process of micro development where they looked at how many devices could be implanted in kind of cadaver hearts, and they were able to get in at least 3 in the smallest size hearts that they looked at, and I think it was a series of maybe a dozen or so hearts, and so that gives you based on the current longevity of at least the microsystem a good amount of time that you're working with. I would argue that if you have 3 full life cycles of the currently available leadless devices, that this field is moving fast enough that things will be pretty different by the time you're looking to implant a fourth.
Excellent. I could talk to you guys for the next hour, but unfortunately we have more agenda to get to. So thanks to all the presenters for your great insights into discussing the topics and of course your presentations.